This is Jalan diagnostic criteria for toxic microcolon, and again, these can be uh, basis of question in competitive examination. So, radiographic evidence of colonic dilatation. There is classic finding of more than 5.5 centimeter in transverse colon. If any three of the following are present: fever more than 101.5, tachycardia more than 120, leukocytosis more than 10.5, or anemia, or any one of the following: dehydration, altered mental status, electrolyte abnormality, or hypertension, then we should think on the lines of toxic myocolon. Welcome to our channel, viewers. This video tutorial is about recent advances in the management of ulcerative colitis. We have designed this video tutorial in a way that we have discussed a real life case and evolved our theoretical discussion around that case. We have covered in detail about the definition, diagnosis, grading, and management that includes both medical and surgical. We have tried to cover everything in minute details so that medical student can understand easily about this topic, that is inflammatory bowel disease, ulcerative colitis. So the differential for case of colitis will be infective, ischemic, Crohn's, or radiation. Coming to the further workup in case of ulcerative colitis patient, the most common endoscopic feature of ulcerative colitis is continuous confluent clonic involvement with clear demarcation of inflammation and rectal involvement. That is, there is an abrupt transition from inflamed and normal areas. Endoscopically, severe ulcerative colitis will be there is a mucosal friability. A patient having spontaneous bleeding on examination and deep ulceration. The endoscopic changes characteristically commence at atal bulge. As I said, if the rectum is involved, don't think about the diagnosis. If the rectum is not involved, don't think about the diagnosis of ulcerative colitis or think about other pathology. The demarcation between inflamed and normal areas is usually clear and may occur abruptly within few millimeters. This is another index used for grading the severity of ulcerative colitis, that is ulcerative colitis endoscopic index for severity. It evaluates vascular pattern and the presence of bleeding and ulceration, each within 3 or 4 levels of severity. This is the first validated endoscopic index for severity, UCEIS, that is ulcerative colitis endoscopic index for severity. We have to remember this term. The final ulcerative colitis endoscopic index for severity score is sum of all the 3 or 4 descriptions in the worst affected area of colon visible at schematooscopy. Original UCEIS attributed a score of 1 for normal, and later on a decision was made to change the numbering of the levels, and normal appearance now corresponds to a score of 0, so that the simple sum extends from 0 to 8. So as I said, the ulcerative colitis endoscopic index for severity, these are 3 parameters are evaluated, that is vascular pattern, bleeding, erosion, and ulcer. If vascular pattern is normal, that is 0. And if there is patchy obliteration, is 1, or if it's totally obliterated, then it's 2. As per the bleeding is concerned, none is 0. And if there is a mild mucosal bleeding, then it's 1. If it's luminal bleeding, only 2. And if it is severe luminal bleeding, it is 3. Erosion and ulcers, none is 0. Erosion is 1. Superficial ulcer 2. And deep ulcer is 3. Though UCIS will range from 0 to 8, and it is validated index of severity based on endoscopy or coloscopy. So coming back to our case scenario, we did sigmoidoscopy in this patient, and full length colonoscopy was not done for fear of perforation. Full length is not advisable in case of severe colitis, as is the case in this patient of a young lady. So sigmoidoscopy revealed there was loss of vascularity. They have seen up to 15 centimeter. There was granularity. Mucosa was friable, and mucosal bleed was positive. there was superficial ulceration, and biopsy was taken, and PCR was sent for cytomegalovirus infection. So the UCIS was 2 plus 1 plus 2, 5 will equate. Chronic stenosis, another important diagnosis in case of ulcerative colitis, and in long-standing ulcerative colitis, a chronic stricture signals an increased risk of colorectal cancer. Multiple endoscopic biopsies should be taken to exclude carcinoma. CT colonography is advised if structure is not possible with the endoscope. If the dignity of chronic stenosis is unclear, we should perform surgery, that we should resect the stricture, presuming it to be malignant. Patients with chronic stenosis who had no preoperative sign of pregnancy on CT or endoscopic biopsy, the carcinoma was diagnosed post-operatively in 7.8% of the patient. So there is a high chance of malignancy in a patient with chronic stenosis with ulcerative colitis, and we should treat this patient aggressively, and if we cannot ascertain diagnosis, we should think about the resection. So what are the histopathology features of ulcerative colitis? For diagnosis, we should take minimum 2 biopsies from at least 5 sites, including rectum and ileum. The basal plasmacytosis is the earliest diagnostic feature with the highest positive predictive value. So remember, basal plasmacytosis is a diagnostic feature. Preserved crypt architecture, absence of transparent inflammatory cell infiltrate do not rule out ulcerative colitis at early stage. The other point is the correct diagnosis is reached in approximately 75% of patients if 3 out of the 4 following on histopathology are met. One is severe crypt architectural distortion. Second is severe decreased crypt density. Third is an irregular surface. And fourth is heavy diffuse transparent inflammation in the absence of genuine granulomas. A decreasing gradient of inflammation from distal to proximal favors ulcerative colitis, that is, the rectum is more involved as compared to the descending colon as compared to the transverse colon. So, if there is a decreasing gradient of inflammation from distal to proximal, that favors diagnosis of ulcerative colitis. What are the extra-intestinal manifestations of ulcerative colitis? Anemia is common in UC and found in 21% of all patients, and was also present in our case, which we have discussed. Joint involvement is the second most common extra-intestinal manifestation, 20% of all patients. Osteoporosis should be assessed in all patients with persistently active UC, especially if repeated exposure to corticosteroid or with long disease duration. And that is, as I have already said, that is the rationale for supplementing calcium and vitamin D3. Episcleritis usually respond to topical corticosteroids and NSAIDs, and uveitis if potentially more severe consequences. So anemia, joint involvement, osteoporosis, episcleritis, and uveitis, these are the most common extra-intestinal manifestations, out of which anemia 21% and joint involvement in 20%. Again, the rationale for the basis for these statements is eco guidance, which I have said before also. The hepatobiliary disease is an important consequence of extra-intestinal manifestation in UC, and primary sclerosing cholangitis, that is PSC, is the most important hepatobiliary condition. Cirrhosis, chronic hepatitis, cirrhosis, and gallstone disease, these are all increased in these patients. PSC, that is primary sclerosing cholangitis, is a major risk factor for both cholangiocarcinoma and colorectal cancer. That is, a patient of UC having primary sclerosing cholangitis, the chances of colorectal cancer are very high as compared to a patient who doesn't have hepatobiliary disease in UC. If MRC, that is magnetic resonance cholangiography, is normal and small duct PSC is suspected, we should consider liver biopsy. Ursodeoxycholic acid was shown to improve the level of liver enzymes and to reduce the risk of CRC. So, patient of UC with PSC that is ulcerative colitis with primary sclerosing cholangitis, we should consider supplementing this patient with ursodeoxycholic acid. But no therapy has been shown to reduce time to liver transplantation, cholangiocarcinoma, or death in these patients. The cumulative incidence of colorectal cancer is 1% at 10 years, 3% at 20 years, and 7% at 30 years. So, as the disease duration increases, the chance of malignancy of colorectal cancer increases. The most consistent risk factor of colorectal cancer is primary sclerosing cholangitis, and absolute risk is up to 31%. So, as I have already said, if a patient with ulcerative colitis and having hepatobiliary manifestation in the form of primary sclerosing cholangitis, there are very high chance of 31%, and we should screen and treat this patient more aggressively. When disease activity is limited to rectum without evidence of previous or concurrent endoscopic and or microscopic inflammation of rectum, a regular surveillance colonoscopy is not necessary. In that case, only squamoscopy is necessary. 22% of patients you see with colorectal cancer, the tumor occurred prior to beginning the surveillance colonoscopy. Concurrent primary sclerosing cholangitis, we should do annual surveillance colonoscopy, and irrespective of disease activity, extended duration. Okay. So now, what should be the interval for surveillance colonoscopy in a patient of ulcerative colitis? It is according to the risk. It is annually if patient is high risk, and the criteria for high risk is extensive colitis with severe inflammation, first relative with colorectal cancer, age less than 50, intraepithelial neoplasia in any of the previous screening colonic biopsy, or primary sclerosing cholangitis, and stenosis. I have already emphasized that any patient ulcerative colitis with stenosis, we have to treat this as a case of malignancy unless proved otherwise. For intermediate risk patient, the colonoscopy is recommended every 2 to 3 years, and the criteria for intermediate risk is colitis with mild to moderate inflammation, and it is according to histological diagnosis, first degree relative with colorectal cancer, age less than equal to 50 years, and if they are extensive pseudopolyps. Screening colonoscopy is recommended every 4 years if patient is in low risk and if he doesn't have any of the criteria for high or intermediate risk for the colorectal cancer. So coming back to the case scenario that we have discussed, 25-year-old lady with extensive or severe ulcerative colitis, 6-month history. Her CMV DNA was negative. She doesn't have cytomegalovirus infection, and Clostridium difficile was already ruled out. The histopathological examination revealed chronic active colitis with basal plasmacytosis, loss of architecture, transmural inflammation. She received 4 blood transfusions in the meantime. We have already started her on broad spectrum antibiotic and metrogyl. We have given a trial of intravenous corticosteroids, but that failed, and we gave IV fluids along with supporting measures. After failed trial of corticosteroids, we gave a challenge of tacrolimus, and she responded. Her stool frequency decreased, and HB became stable around 9.8 gram percent. So, what is the medical management of ulcerative colitis? Detailed discussion is beyond the scope of this video tutorial. Briefly, we have mesalamine, steroids, cyclosporins, thiopurines, and anti-TNF alpha, that is tumor necrosis factor alpha, and vedolizumab. Mesalamine is used for mild to moderate ulcerative colitis for both induction of remission and maintenance. Steroids mainly we use budesonide for mild to moderate ulcerative colitis and prednisolone for moderate, and IV steroids are used for severe ulcerative colitis as we use in this patient. Cyclosporin, again, severe ulcerative colitis after failure of IV steroids, and both steroids and cyclosporin has no role in maintenance. They have only a role in remission of the relief. Thiopurines, azathioprine, mercaptopurine, they are used in addition to the other drugs, and they have main role in the maintenance or remission. Infliximab, adalimumab, golimumab, these are used for moderate to severe ulcerative colitis, which is steroid refractory, and after failure of IV steroids. We will cover in detail on the medical management of ulcerative colitis in different video tutorial. For the meantime, we have to remember that these are the drugs mainly used for a patient of ulcerative colitis, that is mesalamine, steroids, cyclosporin, thiopurines, and vedolizumab. Topical mesalamine is the first line therapy for patient of mild to moderate inflammation. Mesalamine 1 gram suppository OD is preferred initial treatment. Mesalamine foam or enemas are an alternative, or suppository can be given. The suppository delivers the drug more effectively to the rectum, that receive higher concentration as compared to the oral routes, and topical mesalamine is more effective than topical steroids. Combine topical mesalamine with oral mesalamine or topical steroid is more effective. The combinations are more effective. The dose response is up to 1 gram of 5-aminosalicylic acid per day, and there's no further therapeutic advantage of increasing the dose above 1 gram dose for topical application. And once daily topical therapy is as effective as divided doses. For extensive colitis, that is left side ulcerative colitis, which is mild to moderate severe, that will be like E2 as per the Montreal classification, that is extending up to the splenic flexion. We give ASA enema more than or equal to 1 gram per day combined with oral mesalamine, that is more than or equal to 2.4 gram per day. Topical mesalamine is more effective than topical steroids, that I've already said. Topical therapy achieves higher rectal mucosa 5-aminosalicylic acid concentration than oral. Once daily dosing with mesalamine is as effective as divided doses. Again, it's a repetition of the previous talk. For moderate to severe or mild activity not responding to mesalamine, oral beclomethasone dipropionate 5 mg per day is effective, or budesonide 9 mg per day. For severe left side colitis is an indication for hospital admission. Patient with moderate disease may benefit from higher dose of up to 4.8 gram per day. The Ascent 2 trial, the median time of cessation of rectal bleeding was 9 days in patients receiving 4.8 gram of 5-ASA per day, 16 days for patients receiving 2.4 gram per day, and 7 days for combination of 4.8 gram and budesonide combination of budesonide and 5-aminosalicylic acid. So the combination has better stop. So the combination has a better efficacy in inducing the remission. If symptoms deteriorate, rectal bleeding persists beyond 10 to 14 days, or sustained relief from all symptoms has not been achieved after 40 days, additional therapy with oral systemic steroids should be started. For severe ulcerative colitis, confirm the diagnosis, exclude the enteric infection. We have to rule out Clostridium difficile, as I've already emphasized that for every flare-up or for severe colitis, we have to rule out Clostridium difficile infection and CMV infection. IV corticosteroid remain the mainstay of conventional therapy. Therapeutic alternative for rescue of steroid refractory disease are cyclosporin, tacrolimus, or infliximab, and they should be considered early on around day 3. If patient is not responding, like our case which we have discussed in this video, patient failed to respond after 3 days of IV corticosteroids, so we started tacrolimus. High morbidity should be delayed surgery, so active decision making is required. That means if patient doesn't show improvement, so we have to think about emergency surgery early in the disease process. All patients should receive adequate fluid resuscitation and thromboprophylaxis in the form of low molecule beta heparins. Electrolyte abnormalities and anemia should be corrected. They should receive adequate blood transfusion if required, and they are best cared jointly by gastroenterologist and colorectal surgeon. There are few clinical markers which predict colectomy in patients of severe ulcerative colitis. One is Oxford criteria. If after 2 days of IV corticosteroids, if stool frequency is more than 12 per day, the 55% of patients will require colectomy. If frequency is more than 8 per day, between 3rd to 8th day of IV corticosteroid, with CRP more than 45 on day 3, the predicted colectomy rate is 85% during that admission. That means if patient has not responded adequately, or the inflammatory markers are high, the rate of colectomy is high, and these patients will require emergency colectomy up to 85% of cases. So active decision making is warranted, otherwise the mortality rate will rise. Biochemical markers, an ESR more than 75 or a body temperature more than 38 degree on admission. It increases the colectomy rate by 5 to 9 fold. And if there is a lack of response to steroid, as predicted by less than 40% reduction of stool pregnancy within 5 days, that also there is a high chance that these patients will require colectomy, emergency colectomy. So these are the markers that we have to keep in mind that after starting IV corticosteroids or other alternative, if patient not responding or if the inflammatory markers are not coming down, we have to think about the surgery in early course of the disease. If there is a clonic dilatation on X-ray more than 5.5 centimeter or mucosal islands on plain radiograph, 75% of the patient will require colectomy. Presence of islets with more than 3 small bowel loops of gaps, colectomy in 73% of cases. Study from Oxford, 13 out of 14 patients with acute severe ulcerative colitis and ulcerative colitis endoscopic index for severity score of more than 7 or 8 needed rescue therapy with infliximab, cyclosporin, colectomy, or readmission. Deep ulceration, the most severe endoscopic lesions, are located in distal part of colon and can be detected by sigmoidoscopy. So, as I said, the inflammation will be more in the rectum. It gradually increases from proximal to distal. That is, inflammation more in the rectum than the sigmoid. It is less in the descending colon, transverse colon. So, the severe lesion can be detected by sigmoidoscopy because the most affected part will be the distal part of the rectum or sigmoid. Therefore, complete colonoscopy is not necessary and carries an increased risk of perforation in patients with severe ulcerative colitis. Toxic megacolon is one of the complication of ulcerative colitis or severe inflammation. That is total or segmental non-obstructive dilatation of colon more than 5.5 centimeter with systemic toxicity. Then we have to think the patient has developed toxic megacolon. Risk factors for toxic megacolon are hypokalemia, hypomagnesemia, bowel perforation, and antidiarrheal therapy. Early diagnosis of severe colitis, more intensive medical management, and early surgery have reduced the incidence and mortality. In addition to IV hydrocortisone, empirical treatment with oral vancomycin should be considered until stool is confirmed negative for Clostridium difficile toxin, the CDTA should be negative. Where colectomy has been inappropriately delayed, mortality up to 50%. So active decision making is required and thus emergency surgery should not be delayed, otherwise mortality up to 50% has been reported in the literature. The main reference on which my talk is based upon, and viewers can go through these guidelines. There's eco guidelines, and that will be helpful to get more insight into the subject. So, for further managing the rectal stump in this patient, we manage with the help of medical management in the form of mesalamine enema and hydrocortisone foam enemas and maintenance therapy with the mesalamine enemas. Patient responded well, and we counsel the patient to complete our family. And after completion of family, patient was taken up for the completion proctocolectomy, and we did IL pouch anastomosis and coupling loop elastomy. Patient recovered well. Thanks for watching, viewers. I hope you like the video. Please don't forget to like the video and subscribe to our channel. The channel subscription is free for a lifetime. The knowledge is invaluable. Happy learning. Thank you very much.